Menu intents, number one, it is radiation segmentectomy if you want a cure, or you're bridging to transplant, you're downstaging to resection. Otherwise, everything else, you're going for control. So who are the good patients for Y90? So because we're giving such high doses and we are going to obliterate whatever liver tissue that is in our way, the patient should have quite good liver function. So good liver function, Charlesville A5, A6, LP grade 1, ECOG 0 to 1, this is a good patient. Once the patient starts getting to B8, then we really wonder, should we be so aggressive with Y90? Maybe we want to reduce the dose. And certainly BCLCC, ascites, we should really avoid Y90. So as we do more and more Y90, the more of the embolization that we do. So embolization is simply to block the blood vessel. We no longer do prophylactic embolization of, say, the GDA or the cystic artery. We only do when it's needed. So for example, you're trying to protect another segment that's in the way that you cannot super selectively cannulate, that's when we do the embolization. So we also do not routinely embolize the cystic artery. I think it's okay to give the MAA if you see a prominent cystic artery. Even when it comes to treatment, maybe just block it off with a little bit of gel foam rather than embolization. You're going to run into more troubles with ischemic cholecystitis. Something that we try and teach at Singapore General Hospital is that while we are doing the MAA, where we release the MAA, we want to do a cone beam CT. So this cone beam CT is much like the CT scan that you do, it's just that the contrast is injected with the catheter almost within the liver. So this defines treatment area, and this is quite important. So that we want to see whether there is any uptake in the non-liver areas, and we can also see at the end of the day whether our treatment areas matches up. If it doesn't, between the IR and the nucleomet, there needs to be a discussion. Particle physics is next. So the whole premise of Y90 is that the interventional radiologist will try and find the selective blood supply to the tumor and release the tumor there, release the Y90 there. Now, as we have heard, Y90 is a very small particle, about 50 microns, with beta emission. It's actually also a positron emitter, that's why you can use on the positron pad after that. But the beta is really just 3 mm, so it is actually possible to do your patients as outpatients. And certainly most of my patients who undergo Y90 gets discharged on the same day. We will talk about the dose targets a little bit later, but that's really what we're trying to do. And it's really, at the end of the day, also a balance between how hot the spheres that we want to give and how many spheres do we want to give. And this is an eternal battle because the hotter it is, the less spheres you need. But you don't get so much coverage. So we sometimes fear that if there's not enough coverage, the treatment will not be good. Remember that the penetration of the beta particles is only 3 millimeters, right? So we do need quite good coverage at the end of the day. So whether we have fewer hotter beats or more but less hot beats. And the correct answer is we want them both, right? We want it not too hot, not too cold. We want the perfect amount of beats at the perfect specific activity. It's not easy, but I think within the next 3 to 5 years, we will probably get a better answer. We have seen these indications for Y90. I don't think there's another modality that can go from BCLC-A to BCLC-C. Specifically for BCLC-C, I think for portal vein invasion, I think Y90 is a very good modality. We've heard about this as well. It can be used in intrahepatic cholangio. Generally, for intrahepatic cholangio, if they are on a more advanced stage, it is together with systemic therapy. Metastatic CRC, Y90 can be used after failure of second line.